Hi there, my name is Valmeek or Vic Cadesia. I'm the VP of Clinical Informatics Advanced Analytics at Commonwealth Care Alliance. I'll be talking about the use of analytics to take care of a vulnerable population during COVID-19. But before we get there, I wanted to take a break to remind us how to think. I saw this piece of graffiti outside Harvard Med School on my way into classes one day, and I thought it was unique. For those of you who do NLP, it's already tokenized. The punctuation has already been scrubbed. It's very polite graffiti, and it reminds me to think and stretch a little bit bigger than what we're seeing right now. So you're welcome. The first thing I'll do is I'll talk through what is Commonwealth Care Alliance. What is it? Who are we? Who are our members? The challenge at hand, and what we did, and then future steps. I'll tell you about myself first. Vic for short. I'm a practicing internist, engineer, and informatics guy. Came from the precision medicine world, so lots of germline, somatic, genome, proteomic stuff. I'm sort of the doctor who talks tech, does data, does systems. And what is CCA, Commonwealth Care Alliance? So we are a bit of an unusual animal. We take care of people who are very complex that other people are scared to take care of, more or less. Folks come to us. We have about 40,000-ish members or so. Almost half of them do not speak English as their primary language. We see these individuals as a combination of medical, behavioral, and social overlaps. CCA is this combination of a payer, a care manager, and a direct care provider. So we're unique in the sense that we cut across silos that normally are more comfortable being separated in the U.S. healthcare system. Most of our members have more than 4 chronic health conditions. A good number of them have severe persistent mental health illness, so schizophrenia, depression, bipolar, or some other BH need, and a fair percentage have some substance abuse or alcohol dependence. So all of these factors mean these are people who are vulnerable. They need help in different kinds of ways. CCA, we've been around for about 30 years. We're a national leader in complex care. We are risk-bearing, community-based. We're based in Massachusetts. Risk-bearing here means that we have to take care of the whole person. And what we do is we do part advocacy, we do part payer, provider, care management, as I've explained. The person has some experience with us. We give services, pay for things. Some events happen to that member, and until some end. So our job is to take care of people who are vulnerable and take care of them in ways that is holistic, not just medical. And people who are vulnerable, they are vulnerable in many ways. So medical complexity, many of our members are frail, have diabetes, respiratory conditions, heart conditions. More than 30% of our members fit into this high-risk category, medically speaking. Our members also have many social and environmental risks or obstacles. They are marginalized in our society. Food insecurity, housing is often a problem, and housing is healthcare. And individuals are often at risk for eviction. They live in multi-generational households, congregate or high-density living, and they are dependent on services in the community. They have an increased risk of poor outcome if the services are interrupted, as well as they have increased risk for people coming into the home to do services. So all these put together, sort of the medical, the social, the community risks, these people are at higher risk. They're more vulnerable, even more vulnerable. And one of the first things that happened was that COVID-19 just stressed all of those supports. People who are vulnerable are even more at risk. I'm going to switch gears a little bit and talk about what we did. Looking at our analytics platform at CCA, we started building this about a year ago. And you see on the left here, we have all of our typical data source intake. We have claims that are payment and administrative, EHR or clinical data, insurance data, because we are an insurer. We have care management and social determinant of health data to get that full holistic view of a person. This is a typical tech stack kind of drawing, going from the left, extract, load, transform, analysis, and then use. We approach things from the infrastructure as source, containerization point of view. We use DBT and Netlify to maintain a data lineage to help us stay away from becoming a swamp, which would not be very good at all. We make a lot of heavy use of the Google Cloud Platform services, and we use GitHub as our source code control. We, of course, are a Python shop with MLflow and Kedro. We're using Kedro as a framework to improve our MLOps. And for those of you who are going to be using Kedro with Google Cloud, we recently submitted a pull request for a GCP adapter for Kedro, so you're welcome for that addition. And then, of course, we're using Looker. We've had, I think, a very good experience. We went live last year, so June 2019, and within 15 days, we had our MVP up and running. That's like fast. Now we're using this platform for predictive, descriptive, and prescriptive insights. We take the data ops sort of point of view of things, and we wanted to use all of our data, warts included. So we didn't want to wait for data to be perfect. We wanted to use what we had as fast as we could. And our point of view is that we want to give behavior guiding data to our clinicians and our nurses and our physicians, so that the social worker, the telephonic RN, when he or she or they sees information or data, it's clear what it means, what it's good for, what it's meant to help them get done. Our experience with Looker has been very good. It is a HIPAA compliant platform, of course. We could go fast. We have a very low overhead. We were able to use that modeling layer to get to what matters quickly. Be wrong enough times quickly so that we get to what's compelling as fast as possible. And with a small team, you want to keep your overhead low. It solved one of our continuous integration, continuous deployment challenges. And our use of Google Cloud has also been very, very effective. Again, it's a HIPAA compliant platform, single BAA for all services, which is great for a small team. We don't need a lot of overhead managing things that we don't have to manage. The approach has been sort of serverless managed services, so like BigQuery. Again, low overhead, small team, focus on impact, focus what matters. The tech stack here, it has positioned us for a fairly small team to get to what matters as fast as possible, learn what matters, be able to cycle very quickly, and bring it to people who can take care of vulnerable people. So all of this is, these are technologies to help us get to what matters for people who are vulnerable, fast. Leaning on that infrastructure, on that work, we didn't really have to pivot the thing we built to tackle COVID, because it was built to go fast. It was built to focus on important things. It was built to allow us the ability to find what's important, iterate very quickly. We were able to implement the CDC definition of COVID high risk within 15 minutes. I pushed the button myself. in that semantic layer, click, it was pushed across everybody within a matter of 5 minutes. There was very little lag. Now we're able to absorb results, test results, public health results, really to be sort of data omnivorous, to take in everything that matters, to bring it to people who are tasked with taking care of people who are vulnerable. We've been able to make the information model very powerful, malleable, and we can perfuse COVID-19 information across all pieces that matter. And as of recent check, we have about 350 weekly active users, and there's about 30 looks at data from some clinician every minute. So 30 times a minute, someone is being informed by data and insights to do something good. As far from the member and organization experience point of view, this platform has helped us reach some really important goals. Like, we were able to reach about 95% of our members within the past 90 days, like phone call, physical face-to-face visit. What do you need? Do you have food? Do you have access to your medicines? Sense of isolation? Do you have access to your oxygen that you need at home? And we were able to reorganize how we take care of people who don't navigate our care systems very well. And we have about more than 50,000 virtual visits, more than 5,000 face-to-face encounters. And this performance has been noted in other places. The links down at the bottom there to find, to review other experiences. I think the future, we will be facing a fall and winter where we have to contend with both COVID-19 and flu. And people who are vulnerable, they are at higher risk of dying. So the human cost, the human toll is what we worry about. And how do we meet a person's needs? We have to anticipate their needs. We have to get to them before they find themselves in a difficult situation, which means we have to model things like understand what is an emergency sensitive service or condition or situation. How do we maximize the potency of our face-to-face visits? Because we're probably not going to get more PPE, not more masks, gloves in a way that we need. How do we protect our own staff so that they don't get as sick or as high risk going out to take care of people? Pull from other sources like weather and like fair market housing rent and economic indicators to describe things like risks that may make a person have to go expose themselves, not able to maintain social distancing. And of course, we want to push forward with our sophistication, so we would like to introduce sort of looker actions, for example, as a means to take input back to training of models to predict more things that are important. So altogether, we've had a very good experience with a small team choosing what to care about and what to allow other people to care about, and to focus on being able to go fast, quickly, to find what matters quickly, all in the service of taking care of people who are vulnerable and oftentimes don't have anyone else to take care of them. And this is, of course, a team effort. We see Jerry, Caitlin, June, Ajay, Marilyn, and Shravanti there as part of the data science team at CCA. So thank you for listening to my talk. And there's so much more good that we can do. There's so much more good that data can do, and we can do for each other. Thank you.